Okay, its time is okay. Dear experts and colleges, thank you for attending this academic exchange meeting on thyroid microwave ablation technology. I'm Dr. Anhua Li from Sun Yat-sen University, Cancer Center of China. In recent years, with the continuous improvement of health awareness and the country's increasing attention to the development of medical health, new technological advances have provided many favorable factors for the development of microwave ablation of the thyroid gland as a therapeutic technology. Microwave ablation becomes a new thermal ablation treatment that tutors image guided to transform traditional inversion procedures into the minimally invasive ones, representing a scientific advancement in diagnosis and treatment for both patient and the medical industry. We believe that some microwave ablation will play an increasingly sacred and implement role in the treatment of the different diseases. We hope that all the experts and colleges and doctors will share their insights and engaged in discussion, offering valuable opinions and suggestions for the development of thyroid microwave ablation technology. Thank you all. Today, the speaker is Dr. Han Bin from China. He will share his experience to our meetings doctors, how to do in the thyroid nodules ablation with microwave. Okay, please, Han Bin, doctor.
Okay, can you hear me? First of all, thank you for the introduction of Professor Li. And today I will present. It's my great honor to present a speech here. And the title was Thermal Ablation with Benign Thyroid Nodules, and Bin Han from Shanghai Nice People's Hospital, affiliated to Shanghai Jiao Tong University School of Medicine, and from Department of Endocrinology. So let me have a look. Okay. First part was a brief introduction of thyroid nodule. The introduction of thyroid nodule. From this picture, you can see the left is the normal thyroid, and the right one was thyroid nodule. So thyroid nodules are lesions caused by abnormal proliferation of thyroid cells. There are many reasons for thyroid nodule, such as iodine deficiency, radiation, and genetics, and also diet, etc. To our mind, not only iodine deficiency, also overtake of iodine was also cause the thyroid disease. The second is the clinical symptoms, including pressure symptoms and hormone-related symptoms. The pressure symptoms including hoarseness and foreign body sensation in the throat, and also difficulty in breathing and swallowing caused by the big thyroid nodule. As far as the hormone-related symptoms, there was palpitation, excessive sweating, or trembling of hands, representing hyperthyroidism, and fear of cold, fatigue, Dorsness representing hypothyroidism. The classification of thyroid nodules, as we know, most of the thyroid nodules were benign nodules. Only 5 to 50% of thyroid nodules was malignant. In this picture, you can see in the malignant thyroid nodules, most was papillary thyroid carcinoma, which has PTC, and only a few apart were follicular tumor and mallular carcinoma. So how to differentiate a thyroid nodule, whether it was a good one or a bad one? So here we introduce the thyroid system. As we know, in US, there was ACR thyroids. In Europe, there was EU thyroids. Also in Korea, there were K thyroids. So in China, here is the C thyroids, which was published in the Endocrine journal in 2020. This system was based on the Chinese population, and the rating system include the positive features such as vertical orientation and solid composition, markedly hypoacutic, and micro calcification, and irregular margin of extrathyroid extension, which was each one represent 1 point. The negative features, such as comic tail artifacts, -1 point. So the total point combined together to form the counting value. The counting value including no nodules, -1 point, 0 point, 1 point, and 2 point, and 3 to 4 point, and 5 point, and proved malignancy, which means the fine needle aspiration proved malignancy, representing C-thyroid 6, class 6. And in our department, when the nodule had 1 point, representing C-thyroid 4A, represent malignancy likelihood about 2 to 10%. In this case, we recommend the fine needle aspiration to the patient, especially the nodule was more than 1.5 centimeters in diameter. As far as fine needle aspiration, fine needle aspiration was performed under the immediate guided. Under immediate guided, you can, with the needle and the thyroid tissues was smeared in the glass, and in the microscope, you can see the thyroid cells and to differentiate. The diagnosis and treatment procedures of thyroid nodule, first, based on the history, physical examination, and thyroid function, and ultrasound detection, we can divide it into 2 categories. First, when the TSH was lower in the normal range, so we performed ECT of the thyroid, and when there is hot nodule, we can choose radioactive iodine or surgery or thermal ablation treatment. When TSH was elevated or in the normal range, we can further evaluation using the fine needle aspiration. When fine needle aspiration indicated the nodule was benign thyroid nodule, and we can follow up observation, or the nodule was more than 30 millimeters in diameter, we can choose thermal ablation. When the nodule was undetermined thyroid nodules, we can choose fine needle aspirations in 3 or 6 months later, or we can choose core needle biopsy combined with genetic test or follow-up. When clinical evaluation of the fine needle aspiration confirmed or suspected thyroid cancers, and surgery was the first option. So when we meet the malignant nodules, surgical was the first option. And in some cases, when the nodule was very small and without lymph node malignancy, so we can also choose thermal ablation. When the nodule was benign, we can choose follow-up and surgical treatment or internal medical treatment. TSH suppression treatment, which was not popular in the clinical work. And we can also choose ideal 131 treatment, also ablation treatment, etc. The second part of thermal ablation for thyroid nodules, the surgery versus some thermal ablation. This is the thermal ablation operation scenario. You can see we can perform it in our clinical world with under the image guidance. So the traditional surgery, there was a long scar in the neck, and thermal ablation, there was a needle eye, very small. The traditional surgery, we can lose one side of the thyroid lobe, and under thermal ablation, we preserved most of the normal thyroid function. As far as the thermal ablation, we based on the two guidelines. First is the Chinese guidelines in 2018. The second is the European guidelines, which was published in 2020. The thermal ablation included these 4 types. This is the real-time ultrasound-guided thermal ablation, including radiofrequency, microwave, laser, and HIFO. This is a comparison of 4 methods, and laser ablation, the price was very high, so it was not popular in the clinical work. Also, the HIFO were not popular. Radiofrequency ablation and microwave ablation was most popular in the clinical usage. And in our center, we use microwave ablation. Let's have a look at the thermal ablation indication. First, the nodule was benign in thorough ultrasound and confirmed by fine needle aspiration. And also, there is no history of childhood radiation therapy. And third, refuse surgical intervention and clinical observation. Also, simultaneously meet one of the following conditions: hypothyroidism caused by autonomous nodules, local pressure syndrome, or cosmetic concerns, and the radial recurrence nodule or significantly increased nodule volume after surgery. In these cases, you can choose thermal ablation. And the thermal ablation contraindication included any one of the following. It excluded, such as giant retrosternal goiter or most serous nodules are located behind the sternum for those who cannot undergo surgery or anesthesia. And the staged ablation treatment should be considered. We can divide it into 2 or 3 times to ablation, or opposite vocal cord dysfunction. In these cases, we cannot perform thermal ablation. In case of injury of a laryngeal nerve, also severe coagulation dysfunction, if the patient took the pills of aspirin or other antiplatelet drugs, so the patient cannot perform the thermal ablation. The last one is the incomplete function of important organs such as liver organs or heart function. First, the pre-operation preparations included the physical examinations or medical history, treatment of this disease. If the patient have hypothyroidism, anti-thyroid drugs should be prescribed to maintain the thyroid function. We also needed to have the laboratory tests such as blood regular test, blood type, coagulation functions, hepatitis, HIV, trust, PTH, calcitonin, etc. Imaging examinations including the ultrasound and CT scan, or the patient will have the informed consent form. The patient will tell the efficacy of the procedure and the risk of the thermal ablation. Also fasting and establishing venous access. Here is the thermal ablation procedure. They include preoperative ultrasound examinations, use a contrast-enhanced ultrasound to confirm the range of the ablation. The patient was spin position and neck extension and disinfection in the neck area. The patient have a local anesthesia and fluid isolation with a normal saline. The mobile ablation or fixed ablation was chosen to perform the thermal ablation. When the ablation was ended, contrast-enhanced ultrasound examination was also performed to confirm the successful of thermal ablation. The last one was measurement of the post-operation operative ablation areas. After the operation, we can follow up, use ultrasound after the ablation. The intermittent ultrasound at 1, 3, 6, 12 months after ablation to calculate the volume reduction rate. As we know, the volume reduction rate was very important in the follow-up of thermal ablation. So we can also record symptoms and complications. There was some note for thermal ablation. During the ablation, if the patient is very pain, so we can reduce the power of the microwave or pause the ablation. Second, we can monitor heart rate, blood pressure, and blood oxygen during the ablation. Third, adequate pre-operative communication, informing of risks and cost issues. There was some adverse effects of thermal ablation. The first is the pain in the neck, and second is the nerve injury, such as the laryngeal nerve. So the patient have a local anesthesia. In the procedure, we can talk to the patient and to see the voice change. The third is the bleeding. Sometimes the bleeding was fatal, so we can avoid the bleeding in the procedure. The third part is the clinical course of the thyroid nodule ablation. The patient one was female, 60 years old. Fine needle aspiration indicated the size of the thyroid. In this ultrasound image, we can see clearly there were solid tissues and the liquid tissues. It was a mixed thyroid nodule. The diameter was 44.6 millimeters. So the first step was not thermal ablation. The first step was acido ablation. So in the purpose of acido ablation is to shrink the nodule. We can see in this procedure, the acido was frequently injected into the cyst. Have the thoroughly wash of the cyst. So after the acido ablation, one month after acido ablation, the volume was reduced significantly. So you can see clearly the diameter reduced to 60.5 millimeters. In this case, and we performed thermal ablation. First step is the liquid isolation. We use normal saline as the liquid isolate. This is a carotid artery. This is a nodule. So there was a safety area from the carotid artery from the thyroid nodule. So the thoroughly liquid isolation from the thyroid nodule from laryngeal nerve to avoid the nerve injury, and then we can safely to perform the microwave ablation. So you can see here is the needle tip, and the needle tip cannot beyond the margin of the thyroid nodule. It's within the thyroid nodule. You can see here is the procedure of ablation. in different lines. So you can see here, the thyroid nodule was very far from the carotid artery, so our procedure is very safe. Let's see, the second patient was female and 45 years old. Finding the aspiration indicated nodular goiter. The diameter was 60.9 millimeters. You can see the nodule was very large. First, they performed preoperative angiography. The carotid artery has contrast enhanced ultrasound. You can see the nodule has a contrast infusion, and there was cyst in the nodule. In some part of the nodule, it was a sponge form. So the next step is the liquid isolation from the carotid artery from the nodule. You can see the nodule was very, very large. Here is the needle tip. Here is the needle tip to inject normal saline. The next, we perform microwave ablation. So you can see there was liquid in this nodule. So it was very slow, and we carefully ablate every line of the nodule. This is the needle tip. You can see it was inside the margin of the thyroid nodule. So next was post-operative angiography. There is the carotid artery. You can see this is the normal thyroid tissue. This is the nodule. Here with the normal thyroid tissue, and in this procedure, we preserved most of the normal thyroid function. Only the nodule was ablated. Here is the third patient. Patient was a female, 72 years old, have the thyroid nodule for 12 years. She had hyperthyroidism, started taking Maximazo 5 milligrams QD 6 months ago. The ECT indicated the enlarged of the right lobby of the thyroid gland with enhanced technique uptake, suggesting nodular goiter with hyperthyroidism. Ideal 131 uptake shows that 2 hours, 6 hours, 24 hours, 24 hours ideal uptake rate is higher than normal range, and the fine needle aspiration indicated the right upper pole nodule, nodular goiter, right lower pole nodule, and follicular adenoma. Here is the ultrasound image. The maximum diameter of 40.4 millimeter with calcification in the nodule. This is the ECT image. You can see here is the autonomous functioning thyroid nodule in the right lobby of the thyroid. First step is the preoperative angiography. You can see in this nodule the infusion of blood is very there will also cyst in this nodule. And after thermal ablation, the post-operative angiography indicated the nodule was ablated. Here is the normal thyroid tissue, and here is the nodule. Most of the nodule was ablated. Most of the nodule was ablated. So here is the before the operation, the autonomous functioning thyroid nodule was present here. And after operation, the ECT indicated here is no autonomous functioning thyroid nodules. So the thermal ablation totally cured the autonomous functioning thyroid nodule. In the follow-up, you can see half year before thermal ablation, the patient started to Maximazo treatment. The TSH was lower in normal range, and FT3 and FT4 was higher than the normal range. And 2 days before thermal ablation, the patient stopped anti-thyroid drugs, and TSH was a little bit lower than the normal range, and FT3 and FT4 was in the normal range. And 2 days after thermal ablation, and 2 weeks, 1 month after thermal ablation, the TSH was also lower than the normal range. 5 months after thermal ablation, and 8 months after thermal ablation, the TSH and thyroid function was in the normal range. However, 11 months after thermal ablation, the TSH started to decrease in the normal range. Even in the 21 months after thermal ablation. However, the FT3 and FT4 was still in the normal range without taking anti-thyroid drugs. We can also see the TG level after the thermal ablation was greatly increased. After that, it was slowly decreased to 240 after 80 months of thermal ablation. So in the end, we can have a summary. So the thermal ablation to the benign celled nodules have the very good clinical effect, and it will after follow up and surgical. Thermal ablation is another method to treat benign celled nodules. So the treatment conception was improved in our clinical work. So thank you for your attention.
Thank you, Dr. Hanbin. It's very nice presentation about thyroid gland thermal ablation. Thank you so much. Now everybody can talk, discussion about this topic. Any questions?
Hi, good morning, everyone. I'm Barry. I respond for the New York market. I just want to introduce the Dr. Shah Jartin. Hi, Dr. Shah. I'm not
Hi.
sure.
You can call me Bean.
Dr. Bean. Yeah, thank you for Dr. Bean. Very nice and a very wonderful, great lectures. I want just to introduce the Dr. Jatin Saha, and he is a key figure in head and neck surgery and marrow salon catering, and he's made huge contributions to the improving the techniques in head and neck cancer treatment. Hi, Dr. Shah, can you hear me?
Yes, I
Yeah.
can hear you. It was a very nice presentation. I enjoyed it. Unfortunately, I have to leave for another meeting, so I will be very brief. I think, the role for thermal or microwave ablation of small thyroid nodules is here to stay. It avoids the need for surgery, and particularly in anxious patients, it is an excellent modality of intervention, relatively non-invasive and effective. So I'm all in support of these approaches. Whether you use thermal or microwave ablation is the choice of the clinician and the available expertise. But I think it is here to stay, and I want to compliment you for organizing this excellent talk by Dr. Han.
Thank you.
Thank you, Dr. Han. Thank you, Dr. Shah. And it's very honored to have you. Thank you once again. So do you have any problems about the topic we're discussing? The Dr. Han, and also there are so many experts they can exchange the experience.
No, I have no further questions. Thank you.
Thank you. Thank you so much for joining us. Thank you once again. Thank you for attending us. Your insight will really add our conversation. Thank you.
Hi, everyone. I'm Kevin. I'm Kevin Dunn, regional manager. Can you hear me?
Yes.
Regional manager of Los Angeles. So, let me first introduce the Dr. Fazzetti. Dr. Fazzetti is the endocrine expert in the City of Hope. So, right now, he asked question to Dr. Han. Do each patient need to angiography to do this procedure? Thank you.
Thank you for your question, and you can in every patient before thermal ablation, we perform preoperative angiography to confirm the margin of the thyroid nodule and also which part is rich in blood. And in this case, we can ablate that blood with higher energy. So after thermal ablation, we have the post-operative angiography, and we can contrast before and after operation to confirm our thermal ablation is successfully ablated and successfully ablated most of the thyroid nodules in our process. So that's our purpose. Thank you.
Hi, doctor. I have a question. I see one of the patients you do ablation procedure. You use ethanol ablation first. So is this every patient you need to use ethanol ablation first before microablation?
No. In some cases, when the patient have the mixed nodule, mixed with the sized part and the solid part, in this case, we first use ethanol ablation. After ethanol ablation, the thyroid nodule will shrink. You can see for the before the ethanol ablation, the diameter was 44 millimeters, and after ethanol ablation, it was 16.5 millimeters. So when the nodule was very large, it was unsafe to have thermal ablation. When it was shrunk to 60.5 millimeters, it was very safe to have thermal ablation. After the ethanol ablation, there was no bleeding inside the nodule, so it was very safe in the second thermal ablation.
Well, thank you for your share. Thank you.
Hello, Dr. Bing. I'm Chloe from Stanford University and also a doctor from Peking University People's Hospital, and very nice presentation. I have a question. How does thermal ablation compare with traditional surgical methods in terms of patient satisfaction and the recovery time for the treatment of benign thyroid nodules in your institution? Thank you.
Okay, thank you for your question. And in this picture, here is a big difference between traditional surgery and thermal ablation. And the traditional surgery, you can see here, after the surgery, the patient half part of the thyroid gland. Yes. And after thermal ablation, the thyroid function was greatly preserved in the patient. So in our center, when the patient have benign thyroid nodules, the first choice is thermal ablation, not the traditional surgery. And we can also see some patients with scar in the neck after the history, after we collect the clinical history, the patient have the benign thyroid nodule, which was surgery treated in the 20 years ago. So in these years, the benign thyroid nodule was treated with thermal ablation. And in our hospital, this patient, the patient in our ward stay for only 1 day. And after the thermal ablation, the second day, the patient was leave the hospital and go to their home. So after traditional surgery, the patient stay in hospital for 3 to 5 days. So it was very convenient to the patient. And also the bleeding in the thermal ablation was very, very decreased compared to the traditional surgery.
Okay, thank you.
Hi, Dr. Han. Another question from the Dr. Fazeli. She asked, what kind of angiography would you order?
Traditionally, we use a contrast-enhanced ultrasound. Contrast-enhanced ultrasound. I can. Okay. I can check it. Wait me a second. Okay.
While you're checking, good morning, everyone. So I can say that the quality of life and recovery time is not comparable at all. Surgery is surgery. Surgery has complications, and patient goes home and they have to stay in bed for at least a week. They cannot move, as a recovery time. But ablation does not have any recovery time. I mean, patient goes home the same day in many centers and take some pain medication, and the next day they're functional. So that's the recovery part. What I want to ask was the size of the nodule. Do you have any maximum size that you would say we don't do ablation anymore as far as the volume? Because we see that the higher the nodule sizes for like RFA, the efficacy of the procedure comes down, and the percentage of the shrink is less. Do you have any maximum size that you would say, or I mean, you probably would say we're going to do it in 2 sessions, 3 sessions, something like that?
Okay. Thank you for your question. And in our clinical work, we have seen the larger thyroid nodule about 8 centimeters in diameter. So it was a very large thyroid nodule. We can divide it into several times to perform thermal ablation, and after thermal ablation, it was shrinked, and we cannot and it cannot be reduced to the normal normal thyroid nodule, and it was shrinked, and the patient was very happy.
How long
and
you would wait?
Here is the note. It is that when the nodule was very large, the core needle aspiration was needed. Not only the fine needle aspiration, core needle aspiration biopsy was needed to differentiate the nodule, to confirm the nodule was benign. So that's our experience.
How much do you wait between each, like the
as
second
far
session?
as the formal question, we use the sonography to perform the angiography. Sonography to perform angiography.
I'm sorry, what kind of angiography?
Okay, let's good discuss about this technology. Any question?
Hi,
If
Doctor.
not,
This
okay,
is
Linda. Okay, Linda.
yeah, this is Linda, Regional Sales Manager for Massachusetts region. Dr. Daniel Kim, he's Chief of Head and Neck Surgery at UMass Boston. He could not come to this meeting due to his patient's appointments this morning. He would like to ask a question that do you use those saline barriers liquid for all the procedures?
Okay, thank you for your questions. And in our okay. So in our clinical work, when the nodule was very large and it was near the carotid artery and the laryngeal nerve, we can use liquid isolation. When the nodule was not very large and was far away from the important structures in the neck, in these cases, we are not perform liquid isolation. So it depend. On the distance from the carotid artery and whether or not the nodule was close to the margin of the thyroid.
I see. Also, the second question he has, similar to Dr. Fatzley, is what's the largest size that you will perform a microwave ablation on the nodule? You mentioned 8 to 10 centimeters. Did I hear wrong?
Yes, 8 to 10 centimeters in maximum diameter. Yes, it's true. And in this case, we divided into different times.
Hi, Dr.
Okay,
Bing.
thank you.
Hi, Dr. Bing. Here is Chloe.
Hi.
You mentioned bleeding is one of the most significant complications after thermal ablation. So I wanted to ask you, how do you treat different levels of bleeding after thermal ablation? Thank you.
Okay. You mean the nerve injury, laryngeal nerve
I
injury?
mean bleeding.
Bleeding. Okay. uh, the when bleeding, and we can use the pressure in the neck. This is the easy method to stop the bleeding. We can use our we can use two hands and pressure in the neck of the patient. From the two sides, and you can.
And another question is, you mean just press the boots, but what should be done if the bleeding doesn't stop?
Pardon?
I mean, what should be done if the bleeding doesn't stop? If that continue bleeding?
Okay. So we can have the ultrasound test, and we can clearly see whether or not it will still bleeding inside the thyroid, So the bleeding, when it is still bleeding and the patient have symptoms in breath, so you can ask the patient whether or not it was hard to breathe, and you can also monitor the blood oxygen. So in some cases, when it was still bleeding, and you can ask the patient.
Thank you.
The last question, the doctor want to know what kind of angiography would you order? I don't know what the doctor mean. Is he mean use what kind of contrast agent to inject from your leg or from your arm? So inject what kind of vessel?
So we use Sonovy as a contrast agent. Sonovy represents the surface high flow rate microbubbles. Surface high flow rate microbubbles. So it will clearly represent under the image guided ablation. It was not used in the CT scan or MRI scan. The contrast was specifically used in the ultrasound.
Dr. Han, you can see the chat. Some question in the chat.
Okay, where is the chat?
Yes, Dr. Fazeli raise another question.
Where is the chat? So where is the chat?
Yeah.
Chat, where is the chat? Oh, okay. I see. How long you wait for the second ablation?
Yeah.
Also, do you do two nodules at the same time? Yes. When nodule was very large, we divided into 2 or 3 times how long we'll wait for a second, about 3 to 6 months for the second ablation. Also, we do thermal ablation for 2 nodules at the same time if the nodule was not very large. If the nodule was 8 to 10 centimeters in diameter, we cannot perform it in the same time with another small nodule in the opposite side. So we cannot perform it in the same time when the nodule is too large. Also, we can see what kind of angiography would you order. So we ordered the sound wave, which was specifically used in the ultrasound. So that was very different from the CT scan or MRI scan. Do you do angiography for each patient? Yes. In every patient with thermal ablation, before and after ablation, we do angiography. Do you do angiography for each? Warm welcome. Okay, that's all.
Okay. Thanks for Dr. Han. In my experience, if the nodule smaller than 3 centimeter, I can do the 2 nodules together at a time to ablation 2 nodules together.
Okay, thank you, Professor Lee.
Yeah. Okay. Now it's time we will say goodbye. Very thanks the speakers, Dr. Han Bin, and out of experience doctors from American. Now the thermal ablation of the thyroid nodule is more and more experienced in China now, because too many patients need to do the treatment by inverse technology with minerally the inversion in patient. So if very thanks, everybody have a good academic exchanges each other. Thank you all. Thank you, Dr. Han Bin.
Thank you. Have a good weekend.
Okay.
Thank you.
Have a good weekend. Have a good weekend. Thank you.
Thank you.
Thank you